everyone. We're starting our webinar. Thank you for joining us today. I'm Dr. Radiat Zarihun. I'll be your moderator for today's webinar, so stay with us. Today, we'll discuss on dental cares management and special health care needs patients with Dr. Mohammad Alkeshan. So Dr. Mohammad is a consultant in pediatric dentistry and head of dental department of special needs department at King Faisal Hospital in Makkah. Dr. Alkeshan has obtained his Bachelor in Dental Science degree in Faculty of Dentistry, Georgia University of Science and Technology in 2012, a Korean Board in Pediatric Dentistry, Seoul National University Dental Hospital at Seoul, now South Korean in 2021, and ongoing fellowship in special needs of dentistry. Dr. Mohammad has worked as a co-director at King Faisal Hospital, a co-director of Primary Healthcare Center in Arfat Makkah Hospital, and medical director at Arfat Hospital in Makkah, and he is the head of Dental Special Care Dentistry Department at King Faisal Hospital from 2024 up to now. So as we all know, understanding and addressing the specific needs of patients with special health care needs is very essential for providing equitable dental care, promoting better oral health outcomes, and also reducing overall burden of the dental disease. So for our participants, you can use the chat box for any questions you have, and we'll address them at the end of the session. We also encourage you to share your thoughts in the chat box. Without further ado, let's dive into our topic, and I will handle it over to Dr. Mohammad. So, Dr. Mohammad, you can speak now.
Assalamu alaikum. Good evening. My name is Mohammad Alkeshan, consultant in pediatric dentistry and a fellowship in special care dentistry. Today I will talk about dental caries management and special care needs patients. In the beginning, I want to thank the Ethiopian Dental Professional Association for the invitation, and it's my pleasure to be with you today and learn from each other and how we can provide a high quality service for special needs patients. Starting with the contents of the presentation. American Association of Pediatric Dentistry defined children of special health care needs as those who have a disability that affect daily life activity and influence the delivery of health care, including dental care. A wide variety of physical, developmental, mental, sensory, behavioral, and emotional environments that require a medical management. Children of special health care need represent around 10% of the world's population live with disabilities. The patient age, the severity of the environment, and the living condition may influence oral health. Health conditions don't necessarily result in a disability, and the disability are not necessarily combined by the ongoing health problem. The contemporary understanding is that the nature and the severity of the disability are not only a product of underlying medical condition, but also a function of the demand, expectation, and human respective. People with disability should not be excluded from full participation in all aspects of society. Special care patient often a complex medical, psychological, or social need. A multidisciplinary team approach ensure that these patients receive a safe, effective, and holistic care. A multidisciplinary team ensure safe, patient-centered, and holistic care for special care patients, in dentistry by combining expertise, improving communication, and addressing both medical and psychological needs. Many children with a special healthcare need are best managed initially by a multidisciplinary team in which a dentist is available. And there is a big responsibility toward a pediatric dentist to provide a more preventive procedure such as oral hygiene and restoration and behavior management during the procedure. The value of the multidisciplinary team brings together a professional from different disciplines to provide comprehensive, coordinated, and holistic care as we see in the slides. In short, a multidisciplinary team maximizes resources, ensure holistic care, improve outcomes, and support both patients and family by combining expertise across multiple fields. The barrier to provision of necessary dental care range from physical barrier in practice, economic, to inadequate education and lack of communication, lack of dentist training or comfort training because of complexity of child or adult's medical condition or behavior challenge was also reported barrier. Dental care percentage of the population who needed but didn't obtain a health care still high because of cost barrier. Physical or structural barrier accessibility issue. Many dental clinics lack wheelchair and wide doors or adjustable chair, inadequate equipment, specialized tool and device to treat children with a physical or congenital disability may be unavailable. Transportation difficulties getting to clinics can be challenging with this patient, especially in rural area. Second barrier, financial barrier, high cost of care, specialized dental services are often more expensive, limited insurance coverage. Some health insurance plans don't cover special dental needs. Third one, professional or provider barrier, lack of a trained dentist. I think this is the major barrier to treat this type of patient. Professional or provider barrier, lack of a trained dentist. Many dentists are not trained in handling children or adults with behavior, congenital or physical challenging. Fear or discomfort from a provider. Some dentists may avoid treating special care needs people due to fear or feeling they cannot help them very well. Or there is no experience to dealing with this type of patient or managing special needs. Limited interdisciplinary collaboration with other departments, poor coordination between medical, dental, and therapy teams can affect care. Number 4, behavior and congenital barrier, children anxiety or fear. Some children with sensory sensitivity or autism may resist dental procedure, communication difficulty, family and social barrier, parental knowledge gaps. Family may not know the importance of early dental care. Cultural belief about disability may prevent seeking care. Time constraint or frequent medical appointment can make dental visit difficult to schedule. And the policy system barrier, limited government support, few public programs specifically target dental care for children or adults with special needs. Fragmented service, lack of integration between health, education, and social service can limit access. Access to the dental service for special needed people need multiple healthcare provider because of complex medical conditions of the cases. deliver care regardless of families' ability to pay may actually shield a families from some of the burden or extra associated costs and help to financial barrier for families or for families, for example, transportation fees. And here is some of helpful strategies to improve the access, training dental professional to work with special needs children and adults, multidisciplinary care teams, dentists and pediatrician and therapists, community-based program offering affordable care, parent and caregiver education on oral hygiene practice, policy changing to expand insurance coverage and accessibility, and as we said, access to the dental service for special healthcare people is essential, but often limited due to financial, structural, and behavioral barrier. Solution is involve education, training, policy, and support the network across healthcare field. Over the past of 4 decades, various frameworks have been developed to help understanding healthcare access dynamics. One recent and comprehensive framework is LAVASC, conceptual framework for healthcare access, published in 2013 after extensive review of existing literature on healthcare access. This framework offers a multi-dimensional perspective on healthcare access within the context of health system. Uh, it takes into account socioeconomic determinants and incorporate 5 corresponding abilities of individual and population to seek, to reach, and to pay, and to engage in healthcare access, unlike approach that focus on health system failures. LAVAC's framework allow research to explore barrier to access resulting from individual abilities to seek, as we say, with access and defined in the framework economy base the opportunity to identify healthcare service while meeting individual needs access. In summary, access require a proper documentation, financial support, specialized facility, trained provider, and caregiver involvement. Number one, medical and dental history, comprehensive medical record, diagnosis, medication, and allergies. Brief dental history, including treatment and difficulties, referral and authorization, referral from pediatrician, family physician, and specialist. Financial coverage assistant program or community-based subsidies for shared family, specialized dental facility clinic with wheelchair and accessibility, adaptive dental chair. All of these can help us to improve the access. In first visit, and according to the access to the dental chair, treating the patient in their own wheelchair using a variety of headrest attachment make the access easier for both the patient and dentist. As a general rule, it is always better to treating the patient to ask the patient how much or little help they require and not to assume that they need help. It's important to remember that some people have conditions such as rheumatoid arthritis, whereby being touched can be painful and they may prefer to transfer without help. This design eliminates the risk of accident during the transfer of patients from wheelchairs to dental units. Recent innovation for patients who should not be moved from their wheelchair have included fixed and portable wheelchair reclining platforms with integrated headrest. There are a number of designs now available, manual and electronic controls. Some patients cannot or should not be transferred, as we said, from their wheelchair for dental treatment. That's why in 2004, the Japanese team developed and evaluated a dental unit suitable for both wheelchairs and general patients, which allowing a patient to receive a dental treatment in a safe and comfortable position. Access to the mouth to achieve the best position in dental chair, the patient body should be well supported, joints and muscle should be in the rest position. If the patient has uncontrolled limb or movement, then safeguarding will need to be put in place to prevent them from clawing against equipment. Like we can use a bamboo board or BD wrap and mouth probe during the examination. After finishing from the value of multidisciplinary team and the barrier of treating special needs patient, now we will talk about caries management by risk assessment. Dental caries refer to the demineralization of teeth caused by acids produced by acidogenic bacteria in dental plaque. This demineralization can be inhibited by antimicrobial agents, saliva component, and fluoride, and remineralization may occur through calcium, phosphate, and fluoride present in saliva. The progression and the reversal of dental caries can be explained by the caries balance model. According to this model, the direction of caries progression is determined by the balance between a protective factor and pathological factor. Pathological factor include acid-producing bacteria, the intake of fermentable carbohydrate, and impaired saliva function. Protective factor include normal saliva function, calcium, phosphate, and fluoride necessary for remineralization, as well as antimicrobial agent. Let us look at the why caries preventing using caries management by risk assessment is important. Early childhood caries is experienced by many children worldwide and can cause various negative effects such as difficulty in chewing, pain, loss of appetite and weight loss, and sleep disturbance. According to a study conducted on more than 200 children between the age of 3 and 5, through interviews with both the children and their parents, early childhood caries was found to significantly reduce oral health related quality of life and compared to the children without the condition. 1 month after restoration of all teeth requiring treatment, improvement in quality of life were observed. In addition, according to 8-year study conducted on more than 500 children aged from 3 to 5 years to examine the relationship between caries in primary teeth and caries in permanent teeth. Caries in the primary dentition showed a positive correlation with caries in the permanent dentition. This indicates the caries in primary teeth can be used to predict the occurrence of caries in permanent teeth. The graph on the right of slide, the predictive rate of permanent teeth caries based on each primary teeth, showing that caries in the mandibular primary molar were the strongest predictor of permanent teeth caries. Therefore, since caries in the primary dentition are highly likely to progress into caries in the permanent dentition, early preference of caries is essential. Let's examine the component of the stage caries management by risk assessment. The first stage is the caries risk assessment stage, and the second stage is the stage that determines the level of risk. The final stage is the clinical protocol, which provides a treatment plan to the patient. This is a caries risk assessment form published in 2021. It consists of risk factor, protective factor, and disease indicator, which remain the same, but the question vary slightly depending on age, Among these, the top two rows of the chart are risk factors and protective factors that the patient must answer, while the bottom two rows are risk factor and disease indicator that the clinician check through the clinical examination. After assessing the risk of caries, the second step is to determine the level of caries risk. The following is the guideline for determining caries risk level in children under 6 years old. There are four categories. The low risk group include cases with no disease indicator, few or no risk factor, and protective factor. The moderate risk group include cases with no disease indicator, where risk factor and protective factor are balanced. The high risk group include cases with one or more disease indicator, or cases without disease indicator but where risk factor outweigh protective factors. Finally, the very high risk group refer to cases within the high risk category where caries are very severe or extensive. After determining the level of caries risk, the final step is the clinical protocol. Caries management by risk assessment provides a guideline that allows systemic caries management according to the level of risk. These guidelines include the timing of a clinical examination, such as salivary test, oral examination, and radiograph, as well as preventive measures such as fluoride, xylitol, and bed and fissure sealants, and recommendation for antimicrobial use. The difference according to age are that for children aged 6 and older, chemical therapies such as fluoride toothpaste use and antimicrobial are recommended, whereas for children under 6-year-old is in addition to chemical therapy, counseling that can motivate caregiver, setting personal goals, and periodic follow-up on those goals are emphasized. Next, let's explore how caries management by risk assessment can be applied more effectively in clinical practice. First, the use of a QRA was considered. This is intended to address limitation of conventional caries management by risk assessment. The clinician must check for caries, restoration, and plaque during the oral examination. Using this device helps detecting caries and aesthetic resin restoration that may be missed by the visual inspection alone. Therapy reducing diagnostic variability between a clinician. Additionally, it allows assessment of plaque accumulation without the use of plaque disclosing agents. The best way to carry out oral examination and radiograph X-ray for patients with special healthcare needs depend on the individual's medical, physical, or congenital and behavior condition. The goal is always to balance accuracy and safety and patient comfort. Evidence-based conclusions start with the least invasive approach, behavior management plus modified positioning. Use extraoral radiograph when intraoral film are not feasible. Sedation or general anesthesia should be reserved for cases where behavior or medical needs make standard imaging impossible. Always follow the as much to decrease the show the patient to the any X-ray to minimize the radiation for the patient. Management and preventive dentistry. Preventive and management strategy in a special needs patient require customization and interdisciplinary collaboration. Emphasis should be on the early prevention. Minimally invasive dentistry should be used during this stage. Regular follow-up empowering a caregiver to play an active role. Parents can be helpful in assessing the child. Children with developmental disability may require partial or total assistance in oral care, depending on their mental and physical capabilities. Home and dental care should begin in infancy. Home dental care should be started as soon as possible. The dentist should teach the parent to gently cleanse the incisor daily with a soft cloth or infant toothbrush. For older children who are unwilling or physically unable to cooperate, the dentist should teach the parent or guardian to clean teeth twice a day using a correct toothbrushing techniques. Safely immobilization the child when necessary, as shown in the figures. Several positions for toothbrushing that permit a firm control and support of the child, adequate feasibility and convenient position of the adult with reasonable comfort for both adult and child. Positions most commonly used for children requiring oral care assistance are as follows. The standing or sitting child is placed in front of the adult so that the adult can cradle the child's head with one hand while using the other hand to brush the teeth. Or the child reclines on the sofa or bed with the head angled backward on the patient laps. The parents face each other as shown in the photo with other knees touching. The child are placed on the one parent's lap. The extremely difficult patient is isolated in open area and reclined in the brusher's lap. The patient is then immobilized by extra attendant while the brusher institutes proper oral care. If child cannot be adequately immobilized by one person, then both parent and any other assistant may be needed to complete the home dental care procedure. Fluoride varnish is a useful form of topical fluoride in patients with impairment and intellectual disability, since its application doesn't require prolonged isolation of the dental arch and its moisture tolerant sitting in the presence of saliva. Provide a high concentration of fluoride directly to tooth surface. Create a prolonged reservoir of fluoride ions to promote remineralization and inhibit demineralization. It's easy and quick and safe to apply in non-cooperative patients compared to gel or rinse. Chlorhexidine indicated to control gingivitis, especially in Down syndrome or other disease, or compensate for the brushing of teeth. Sweeping the gingiva with a 0.2% solution is effective way of modifying application and is well tolerated by patients with disability. But based on the published review, it was concluded that a chlorhexidine rinse, gel, and varnish or a combination of these items with fluoride have a variable effect. Diet and nutrition. Some diseases have feeding difficulties like cerebral palsy and Parkinson's disease. That's why energy-rich food supplements prescribed to ensure adequate nutritional intake have a high carbohydrate and sugar content, which will affect on oral health. Management strategies include recommended sipping water at regular interval during the day and chewing sugar-free gum and a proper non-carcinogenic diet is essential to good preventive program for children and adults with special health care needs. Management and preventive dentistry during if the patient came to our clinic and have any caries or to prevent any future effect to this teeth, several procedures can be used, like bit and fissure sealant and deep occlusal bit and fissure, stainless steel crown using in adult and as intermediate solution, and using in it's common using in during the patient in the pediatric clinic. Requirement needed during the dental treatment like a physical support or protective stabilization. According to protective stabilization, parent must be informed, and this is very important. Parent parent must be informed and must give a consent before protective stabilization is used. It considered necessary and effective way to diagnose and treat patients who need help to controlling their movement during treatment, especially with infants and neuromuscular disorder, or when you are not sure about patient movement during the procedure. Dentists should have a clear understanding of the type of stabilization to be used, the rationale and the duration of use. Uses of protective stabilization should maintain the body position in the dental chair and constant supervision to prevent the patient from rolling out of chair as shown in the figure. Protective stabilization may be indicated when the patient movement could compromise their safety or that of the dental team. Urgent emergency dental care must be provided and no safer alternatives are available. Sedation or general anesthesia is not feasible due to medical or behavior or facility limitation, or the procedure is not that indicated for the general anesthesia, or we have only one tooth or simple procedure. So sedation or general anesthesia, it's not indication at this time. The patient cannot cooperate because of congenital or physical, emotional, or developmental condition. Short procedure are required. It is not indicated when the patient cannot be safely restrained due to the medical condition, respiratory or cardiac or musculoskeletal problem. It is used for stop convenience only, and it should not be done if this procedure only done for the staff convenience. There are less restrictive alternative available. The caregiver patient reviews consent. Nitrous oxide procedure, analgesic and anxiolytic effect can help us in treating some cases some cases of special care patient. As analgesic, nitrous oxide has been used not only in dentistry but also in various medical fields. In it has a long been used for pain relief during childbirth, and it has also been used as a patient-controlled analgesic in cancer patients. The 30% nitrous oxide produced as analgesic effect comparable to 15 milligram of morphine, and it has been shown that the analgesic effect of nitrous oxide is reduced by naloxone, antagonist of morphine. This nitrous oxide, the evidence from a large survey suggests that this technique may be useful alternative to general anesthesia in some cases. The use of conscious sedation with nitrous oxide resulted in successful completion of dental treatment in 83% of cases. If this applied patient cannot be able to breathe adequately through a nasal mask, the use of general anesthesia be justified. As the use of nitrous oxide shifted from general anesthesia to sedation, only small amount of a drug began to be administered, and it has come to be regarded as a safe agent. Many dentists have frequent used nitrous oxide in treatment, and in fact, clinical problems caused by nitrous oxide have been relatively rare. However, since the exact mechanism of action of nitrous oxide has not yet been fully clarified, and because its side effects are often difficult to directly link to cause and effect relationship, debate continuous regarding the adverse effect of nitrous oxide. Therefore, caution should be always be to avoid overuse of nitrous oxide sedation in routine dental treatment. Conscious sedation is considered also option. Before treatment, the following should be assessed. The patient level of consciousness and the medical status are appropriate for conscious sedation. Proper preparation has been carried out. The patient has any allergy or hypersensitivity reaction to the prescription medication. The patient's medical history and current medication should be monitored before applying this option. General anesthesia can help those who are unable to tolerate the pain of dental treatment, such as individuals who experience a fear during dental visit, those with congenital environment or monitor dysfunction, and those unable to tolerate physical stress. Studies of dental fear showed that the prevalence of dental phobia was approximately 10% in general population. Proper pre-anesthetic evaluation and preparation are important. Mild anesthetic complications do occur in people with special needs and disability. Airway management may be difficult because of the anatomic abnormality. Advanced airway device and video-assisted intubation device should be available for tracheal intubation. For those on whom ventilation is difficult, sedation is not recommended. Approximately 10% to 14% of children with syndromes and disability have atlantoaxial instability. And because of complex craniofacial and cardiovascular abnormality can increase the anesthetic complication, such as bradycardia, anesthetic induction, and airway obstruction, and post-intubation crops. Anesthesiologists should be aware of this potential problem and be prepared for this problems. Dental treatment of a person with a disability acquired before the age of 18 and is characterized by significant limitation both in intellectual functions and in adaptive behavior as expressed in conceptual, social, and practical adaptive skills. Patients with disability have a higher incidence of poor oral hygiene, gingivitis, malocclusion, and missing of treated caries. To manage the patient with the intellectual disability, dentists should establishing a dentist-patient-parent staff report and reducing the patient fear about the dental care, and dentists should be repetitive, speak slowly and in simple terms, give only one instruction at a time. Down syndrome is autosomal chromosomal anomaly, trisomy of chromosome 21. Down syndrome patients have many dental anomalies and high incidence to periodontal disease due to immunological deficiency. So that's why some of Down syndrome patient has high incidence to periodontal disease due to immunological deficiency. Down syndrome's patient cooperative and dental procedure can be provided without compromise if the dentist works at slightly slower pace. Caries incidence is reduced in children with Down syndrome. Bruxism regular review program needed. Autism spectrum disorder is complex neurodevelopmental disorder defined as behavioral, syndrome characterized by environment and social interaction. Defects in verbal and nonverbal communication, sensory motor difficulties, and repetitive or restricted behaviors. Autism spectrum disorder patients have multiple medical and behavior problems that make dental treatment difficult. During treatment of autism patients, the use of PDRAB and pre-appointment conscious sedative may be necessary, and use of hand and use of tell, show, do technique are effective. For children with autism spectrum disorder, dental visit can be particularly challenging because increased sensory sensitive and communication difficulties make it harder for them to understanding and cope with the dental environment. General anesthesia is more safer for autism patients, in my opinion, and we should avoid oral sedation medication for autism patients because of difficulty control respiratory depression in autism patients. Autism autism a lifelong condition and cannot be completely cured. Symptoms may change over time and can decrease or even disappear. Factors such as intelligence, IQ, and language use are known to be good predictor of prognosis. Patients with lower IQ and lower functional ability require lifelong supportive environments, whereas these with higher IQ can live and work with minimal assistance. For dental visit of autism patient, all dental staff must be considered, empathic, and knowledge about how to communicate with the patient. In this context, the front desk receptions play a key role in facilitating the patient future visit. Children or adults with autism are more likely to experience emotional discomfort due to distracting stimuli in their environment, such as sounds, light, and taste. Patients require minimum dental treatment that can be completed in 2 visits or fewer. Conscious sedation may be selected as a treatment plan. In our pediatric dental clinic, commonly used sedative include buccal syrup, midazolam usually, and nitrous oxide is used together with nearly all conscious sedation procedure. While the patient is under a sedative, vital sign must be monitored using blood pressure and heart monitor, pulse oximeter, and all procedures should be under monitor. And the second assistant should record these vital signs every 5 minutes. As a conclusion, the responsibility of the dental team to ensure that disabled people are treated equally. Preventive care is considered a major factor in minimize the need for further treatment under general anesthesia. There are many practical ways of facilitating access for the special care patients. Thank you thank you today for your attention, and I hope this lecture was helpful. And if there is any question, I am happy to receive this question, and have a nice night.